Hello, good afternoon, good morning, or good evening, wherever you are. Welcome to the webinar today. My name is Jason Fu. I'm dialing in from Melbourne in Australia. Welcome everyone today to join a session on cholinergic urticaria, insights into classification, diagnosis, and treatment. And today, we have eminent faculty. We'll start off with Professor Sabine Richter from Austria, and Professor Michihiro Hide from Hiroshima, and Professor Atsushi Fukunaga from Osaka. We have about more than 200 registered users today, and altogether close to 60 countries are dialing in from across the globe. So the learning objective today, number one, to examine the classification, pathophysiology, and genetic basis of cholinergic urticaria, followed by discussion on clinical presentation and diagnostic approaches. And we'll conclude with a review treatment options, including non-pharmacologic, pharmacologic, and lifestyle interventions tailored to regional practices and advancements. So this is the outline of the session today. And the session will be CME accredited. And please remember to complete the feedback form at the end of the session today in order to receive the CME point. And please remember to leave your comments and questions in the Q box or the chat on the Zoom window so we can discuss in the Q&A sessions. And there's a survey at the end of the webinar, and we will really appreciate your feedback. And you can look at us on social media and websites as well for all the information and the list of webinar. And without further ado, I will now invite Dr. Sabina.
So, I'm Atsushi Fukunaga from Osaka. I would like to thank the UK Center for giving me the opportunity to speak today. My name is Atsushi Fukunaga. I'm from the Department of Dermatology at Osaka Medical Pharmacological University in Japan. I will be talking about the classification, pathogenesis, and genetics of cholinergic urticaria. I have received the following direct and indirect conflict of interest that related this presentation. OMPU is located in the middle of Japan, between Osaka city and Kyoto city. And OMPU is a UK center and also operates as an Allergy center. Osaka is Japan's second largest city and a vibrant city currently hosting the Osaka Expo, like this. So cholinergic urticaria, first described by Duke in 1924. Cholinergic urticaria subtypes of the chronic inducible urticaria with a chief complaint of itching and or stinging, painful papular wheals that develop simultaneously with sweating. Severe symptoms such as angioedema, respiratory symptoms, and oral anaphylaxis often accompany cholinergic urticaria, despite patients' activity of daily living, including study and work. The eruption may occur anywhere on the body except the palm, soles, and the axilla, and the most commonly affected part of the body is the trunk. It is clinically important to be aware of subtypes and classify patients into those with and without anhidrosis. It is triggered by sweating, but can present in the various clinical forms, including angioedema. It is usually present as a pinpoint size rash, but sometimes it coalesces and spreads. If the rash appears on the face, it may also accompanied by angioedema of the eyelids. we have reported that there are subtypes of cholinergic urticaria. Initially, we assumed there are two subtypes, but we have now added subtypes that present with angioedema of the eyelids and a subtype that is accompanied by anhidrosis. We currently believe there are four subtypes, as shown in the table. A conventional sweat allergy type is deeply involved with histamine and involved in the allergic reaction to sweat. The subtype presenting palpebral angioedema is considered a severe form of conventional sweat allergy type and is associated with sweat allergy and atopic dermatitis occurring more frequently in female. Anhidrosis type is less involved in histamine, and it is associated with sweat. It is not associated with sweat allergy. It's more common in male, and is considered as an independent type. That it is not associated with sweat allergy. And this is a diagram of the pathogenesis of cholinergic urticaria, a subtype without impaired sweating. Conventional sweating allergy type and type with palpebral angioedema are basically related to the same pathology. It is thought that sweat leaks from sweat duct and malassezia-derived antigen contained in the sweat cause mast cell degeneration via IgE. A serum factor is thought to be involved in the follicular type, but the detailed mechanism onset was unknown. Both conventional sweat allergy type, the type with palpebral angioedema type, sweat allergy, and histamine are deeply involved in the pathogenesis. Takahage et al. Reported that patients with cholinergic urticaria without pain and impaired sweating had elevated levels of specific IgE against the purified malassezia antigen MGL1304. The subtype with palpebral angioedema is known to be a strong predisposition to atopy other than subtypes. We reported that 9% of patients conventional sweat allergy type and over half of patients with palpebral angioedema require asthma treatment. Airway hyperresponsiveness is increased in sweat allergy type cholinergic urticaria compared with anhidrosis type. This is a diagram of the pathogenesis of cholinergic urticaria, a subtype with impaired sweating. In the subtype with impaired sweating, the expression of the acetylcholine M3 receptor in the sweat gland secretory area is reduced. It is thought that cholinergic urticaria occurred due to the release of excess acetylcholine from postganglionic fiber endings, but it is unclear whether acetylcholine actually degrades mast cells. In the subtype, serum CEA may be elevated, suggesting sweat gland damage, and may be accompanied by inflammatory cell infiltration around the sweat gland secretory area. We compare the subjective symptoms of patients with sweat allergy type and those with impaired sweating type. The BAS score for each was significantly higher for sweat allergy type patients than that for the cholinergic urticaria with anhidrosis. The BAS score pain for significantly higher for cholinergic urticaria patients with anhidrosis than that for sweat allergy type. We believe that focusing the clinical appearance of cholinergic urticaria is important in differentiating between subgroups. The clinical appearance of cholinergic urticaria shown on the left is considered most typical. But we also encounter patient goose pump, like a rash with a white center and reddish surrounded area, as shown on the right. Therefore, we divided the rash pattern into two groups, the red wheel erythema group and the goose pump group, and analyzed the clinical characteristics of each group. Comparing these two patterns, that the red wheel erythema group was found to have a high rate of sweat allergy, atopic dermatitis, severe itching of the rash. On the other hand, a goose pump group was more likely to be male and had a high rate of sweating dysfunction, impaired anhidrosis and pain. In summary, the goose pump groups is likely to have clinical features of cholinergic urticaria with anhidrosis. Shulmerova et al. Further classified the color and shape of cholinergic urticaria into 6 groups. They reported type 4 has a small, round, anemic clustered wheels and surrounding erythema is associated with angioedema. Type 6, which was a very small punctuated redness and an anemic halo, is associated with impaired sweating. Our report was based on observation in Asian people, while Shulmerova's was based on observation in Caucasian people, so there may be differences in the color tone observed. I checked the genetic factor of the cholinergic urticaria, but there are little genetic research and cholinergic urticaria, so further studies are expected. And this is take-home message. It is important to be aware of the subtype classification of cholinergic urticaria. Each subtype may have different unique clinical characteristics and underlying pathophysiology. Thank you for your attention.
So I continue. I hope you can all hear me. And I will continue with the next talk on clinical presentation and diagnostic approaches. Sorry, these are my potential conflicts of interests. I will talk about the cholinergic urticaria diagnosis. We know that it's one subform of inducible urticaria. And when we look how frequent is cholinergic urticaria among all the other types of inducible urticaria, we see that it's rather frequent. It's maybe not the most frequent one, but in this one study from Brazil, it was the second most frequent one, or here it was the fourth most frequent one, but we see it's a rather frequent form of inducible urticaria. What are the typical triggers, or what patients report us physicians back as a trigger to the symptoms? So the classical possible trigger is when they do exercise, when they do sports, but also if there is some sort of sweating going on. So if they have like passive warming, like in the sauna, or even if it's not so extreme, if it's just very hot climate, and if they are very densely clothed, they have a lot of clothes on them, then they can get the symptoms. Also, in some patients, not in all my experience, they can have triggers like spicy food or stress. So whenever they get sweaty, I think that can be trigger for the symptoms. One thing we should be aware of is there are some cases, some more rare cases, where they need a combination of triggers. So not only the exercise or the sweating is enough, but they need a second trigger. So for example, they need to do the sport outside when it's cold. So they need this kind of combination of cold and sweating to get these symptoms. Or if they do exercise and then they do scratching on the skin. So they need kind of two physical triggers to come together to get the symptoms. Also in this very interesting study from this year, they looked how often was a combination of inducible urticaria present. And when we look here, we see that indeed, sorry, this one moved a bit, symptomatic dermographism and cholinergic urticaria were quite frequently combined, and also cold urticaria and cholinergic urticaria. So we see these are some of the more common combined forms of inducible urticaria that can occur in cholinergic urticaria. What also we should not forget, you can have an inducible urticaria and a chronic spontaneous urticaria. So in this study from Brazil, they not only looked how frequent these types were, but also if they were combined with chronic spontaneous urticaria in the light gray bars. And here we also see for the cholinergic urticaria that in quite a good amount of patients with cholinergic urticaria, they also had spontaneous urticaria. And this is why it is so important, if we have the idea that this patient can have a cholinergic urticaria, to really make sure and check if that subtype of inducible urticaria is present in the patient. And how shall we do it? In the current guideline, it is advised to do provocation and threshold testing in the patients. So provocation testing is something that you might consider doing, or everyone can more or less do it. You do not need such a special equipment. The idea is that you do something with your patients, and maybe just running up and down stairs if you have someone in your buildings, quite tightly closed so that they start sweating, and that they continue this exercise for 10 more minutes, and then you check for the wheals. And with this, you have confirmed the diagnosis. Before, Professor Fukunaga has shown us these different kinds of appearances that can occur. And I just wanted to highlight that again, it makes sense not to say, yeah, wheals, yes, no, but really to have a look. Is it this typical small pinpoint-sized wheals? And maybe go a little bit deeper, check on these different types. So we in Europe, we have seen these three types to be most commonly present. So the typical small wheel surrounded by a reddish flare, but also some patients have areas where there's only flare, and some have more red dotted wheels. This was more common, but the less common forms, they gave us some special hints as shown before. So these types, the type 4 and 5 with the bigger wheels, or these really densely covered wheels, we saw that these were patients that were more severely affected overall, clinically more severe in their clinic. And the special type 6 with this anemic halo around it, these patients with the most problematic reduced sweating. But as I've seen before, this might be different in the region where you are, but this typical red wheel erythema group was also seen in the Asian population. Just this type we have not seen, but it is interesting to keep and look and try to not just say, yeah, wheels, but really to have a proper look on it, because it might really tell us a bit more about the pathophysiology, and that might lead to some sort of different treatments that you want to do with the patients. if you're more deep down and you just not need a provocation test to confirm the diagnosis, but you want to have a threshold testing, so you want to know how severely the patient is affected, one thing that can be done is pulse-controlled ergometry. This is a special protocol over 30 minutes. You need some sort of bike or treadmill where you can put the patients on, and you closely monitor the patients over the time. And when the onset of symptoms occur, that would be one point to monitor, and also the severity of the symptoms that the patient get at the end of the test. What else is recommended to assess in the patient? It's also recommended to assess patient-reported outcomes. And it is recommended in the guidelines that the disease activity, the impact on the quality of life, and the disease control should be monitored with the patients. What tools do we have available for patients with cholinergic urticaria? We need some special tools. We cannot just use the tools that we know from the chronic spontaneous urticaria, the most common form, because they will not work for this form of inducible urticaria. Why? Because at least to some extent, patients can actively avoid the trigger. And so they might seem as if they have less severe disease, but not because they really have less severe disease, but just because patients are avoiding, for example, physical activity. So for that, we had to come up with a modified urticaria activity score specific for cholinergic urticaria. We assess the intensity of wheeling. We are not counting, because you can imagine with all these small pinpoint-sized wheels, you cannot really count anymore. But we're just assessing the severity of the wheeling and also the intensity of the itch. But we also need to keep in mind really the exposure to a possible trigger of the patient. That can be very individual, as I told you before, but we have to ask the patient if he had an exposure to a trigger on that day, and then only those days are counted in the end. And so these scores ends up with an average week score, not as we know in the cholinergic urticaria activities, in the normal urticaria activity score for spontaneous urticaria, where you just add up all the days. So here it's different, because sometimes there might not be a trigger, and so you're not counting those days. So we end up with an average week score without those non-exposure days. So the score can only range from 0 to 6. So this is a bit different here. What else can we do with the patients? We can do a test for the quality of life. There is a specific quality of life questionnaire that had been developed with the patients with 5 different domains, looking on symptoms, functional life, social interaction, the burden of therapy, and their overall emotions. That can be an important tool. And also one tool that we all know in the urticaria world very well, this urticaria control test. That's the good thing. That can be also used in patients with cholinergic urticaria. So we have overall a good range of instruments to diagnose cholinergic urticaria, and this is already my summary. So I've shown you provocation methods to diagnose, to see if the patient has this subform of inducible urticaria. We can then, once we have established the diagnosis, follow the disease with the different tools, with the diaries and questionnaires we have in place, to really see if we do treatment with the patients, how they respond, and how they hopefully improve with the therapy that we are doing. And with that, I'm already at the end of my talk, and I'm happy to receive questions in the end.
Okay, this is Michihiro Hide, and I'm going to talk about treatments in non-pharmacologic, pharmacologic, and lifestyle interventions. Here are my COIs. So, as already mentioned, that cholinergic urticaria is classified as a subtype of chronic inducible urticaria if it continues for 6 weeks or longer. Therefore, treatment algorithm for chronic urticaria is applied for cholinergic urticaria as well. The first line is standard dose second generation antihistamines, followed by the increase of its dose up to 4 times if the standard dose is not sufficient. The second line is the addition of omalizumab with dose and/or interval adjustment as needed. If they are all not effective, add cyclosporine on the second generation antihistamine. In addition to these standard treatments, other medications commonly used for chronic spontaneous urticaria. Several medications or treatments may be applied to cholinergic urticaria based on expert consensus. Some of them are unique to cholinergic urticaria, including sweat desensitization, muscarinic receptor antagonist, propranolol, botulinum toxin, sweat promotion, and satellite ganglion block. The efficacy of updosing second-generation antihistamines has been studied for, in total, 28 patients with cholinergic urticaria, refractory to a standard dose of antihistamine by means of pruritus, Wales, DLQI, a DLQI QoL score. Antihistamine treatment at 4-fold the standard dose significantly reduced pruritus in Wales developed in daily life, and pruritus induced by pulse control ergometry, PCA. So interestingly, antihistamines improved DLQA score significantly in patients with mild disease, but not in severely affected patients. Based on the fact that approximately 2/3 of patients with cholinergic urticaria show type 1 hypersensitivity to the purified sweat antigens, we tried a desensitization of sweat allergy in patients with cholinergic urticaria who were refractory to antihistamines. This trial was conducted before the launch of omalizumab. He showed histamine release from his basophils and skin reactions upon dermal injections of semi-purified sweat antigens prepared from sweat collected from himself. So we began subcutaneous injections of his semi-purified sweat, which was 100,000 diluted, so as to be 1/10 of the threshold his skin reaction. Dose of sweat antigens for injections was increased step by step, and the threshold in skin reactions increased 10-fold with satisfactory level of clinical improvement. Omalizumab is effective for cholinergic urticaria as well as for the other subtypes of urticaria. However, it is noteworthy that the ratio of non-responders to clear responders to 150 or 300 milligram omalizumab appeared to be larger than those in other subtypes of cholinergic inducible urticaria. The efficacy of omalizumab shown by a randomized mixed double-blind and open-label placebo-controlled clinical trial. Of note, female patients appeared to respond better than male patients, and it was reported that trends for lower response rates in patients with cholinergic urticaria compared to other forms of chronic inducible urticaria. Thus, there may be a heterogeneity of chronic cholinergic urticaria in terms of the reactivity to treatments. As shown by as already presented by other speakers, cholinergic urticaria may show certain characteristics in addition to pinhead-sized whales with or without halo and itching, such as anhidrosis and transient dermal pain on sweating. Approximately 2/3 of patients with cholinergic urticaria shows type 1 allergy to sweat antigens, and some of them may develop palpebral angioedema, as shown by Dr. Fukunaga. Considering the action mechanism of omalizumab and antihistamine, patients with cholinergic urticaria and sweat allergy is expected to respond to omalizumab and other medications for chronic spontaneous urticaria. On the other hand, it is hard to explain the mechanism of anhidrosis and dermal pain by just muscle activation. In our center, 11 patients were diagnosed with cholinergic urticaria, developing palpebral angioedema. They were all female and showed histamine release from their basophils in response to at least one component of sweat fractions. They were mostly with comorbidity of atopic dermatitis and all showed a certain level of benefit by antihistamines, in line with Ig-mediated muscle-dependent allergy. On the other hand, steroid pulse therapy may be effective for acquired idiopathic generalized anhidrosis, IGA, including those with cholinergic urticaria. IGA is a disease characterized by idiopathic anhidrosis and often develop pain and small wheals and flare in response to sweating stimuli, which is similar to those to develop symptoms of cholinergic urticaria. In a report of IGA treated with steroid pulse therapy, more than 70% of patients show comorbidity of cholinergic urticaria, and they respond to steroid pulse therapy similarly to patients without cholinergic urticaria. Regarding the efficacy of steroid pulse therapy, response rate of patients with the disease duration less than a year was higher than that of patients with disease duration more than 5 years. The higher efficacy was observed by treatment conducted from March to September compared to that in autumn and winter. Moreover, recurrence rate after steroid pulse therapy was higher in patients 27-year-old or older, and in patients treated in autumn or winter. A really big problem is the treatment of transient dermal pain on sweating. We call this condition as cholinergic dermalgia. It may develop wheal and flare, but may not accompany skin eruptions at all. Most patients are young male and history of sweating activities, mostly by sports, and less associated with other atopic diseases, have normal Ig and no sweat allergy, and used to take sleep. So many of them used to do active sports activities. So this table shows characteristics of two major subtypes of cholinergic urticaria. Well, although Dr. Fukunaga showed four types classification. This table shows just roughly classified atopic and non-atopic. And as a whole, atopic type reaction type patients complain mostly eruptions and itch, whereas non-atopic type patients complain strong pain. Atopic type is aggravated in summer, whereas non-atopic type is aggravated in winter. Atopic type may develop either sex, but non-atopic type is predominantly in male, especially in cholinergic dermalgia. The effect of standard medications of urticaria may be expected for atopic type, but not for non-atopic type. On the other hand, steroid pulse therapy is effective for a substantial population of non-atopic type, especially for IgA. Here is the summary of the effect of various treatments for symptoms in our patients with dermal pain induced by sweating in 14 patients with hypohidrosis and 16 patients without hypohidrosis in dermal pain, eruptions, and in dermal pain, eruptions, and hypohidrosis. And among them, steroid pulse therapy and calcium channel alpha 2 delta ligands such as etizolam and clonazepam showed some efficacy for both patients group, regardless of hypohidrosis. Of note, regular sweating activity was also effective to some extent in both patients group. Now, here is a summary of proposed mechanism of the subtype of cholinergic urticaria. Hyperactions of cholinergic nerve to compensate the decrease of muscarinic M3 receptor and consequential activation of nociceptor. Leakage of sweat, which contains antigens, histamine, and a certain substance to activate nociceptor directly, either directly or by non-Ig dependent mechanism or by the activation of skin mast cells. Because of the strong pain in certain patients induced by sweating, we hypothesized the involvement of bradykinin, which is known to cause pain. We examined the effect of icatibant, a bradykinin B2 receptor antagonist, on sweating-induced dermal pain in patients suffering from symptoms for more than 6 months. Group A patients received icatibant on day 1 and received saline on day 2, while Group B patients received saline on day 1 and icatibant on day 2. They took sauna bath before and after the injections and compared the level of antihistamines, the level of heat-induced pain. Unfortunately, no apparent difference was observed between icatibant and saline in changes of the VAS score and duration of dermal pain induced by heat stimuli by the injections. So here is the possible mechanism of the subtype of cholinergic urticaria and pipelines of new medications. Currently, several medications which inhibit or deplete mast cells, such as BDK inhibitors, MRGPRX2 antagonist, ligand for Siglec-6 and Siglec-8, and anti-c-KIT medications are under development. Although the blockade of bradykinin receptor by icatibant failed, other measures to block nociceptor and blockers of sweat leakage are encouraged to be explored as a therapy for refractory cholinergic urticaria in future. Thank you for your listening.
So this session, I think we have three excellent speakers talking about cholinergic urticaria, from classifications, diagnosis to treatment. And there are a couple of questions coming in. And the first question is the classification validated worldwide? And I think the attendee is from Europe. The attendee mentioned that cholinergic angioedema is not commonly seen in Europe.
So maybe I say something about Europe.
Thank you.
Yeah, I also have seen some patients with angioedema. Also this very symmetric, sometimes swelling of the eyes, and also in a few patients, a little bit swelling of the lip. So I can say I have also seen it in European patients, but not to the extent as we have seen in the pictures, where really it seems like the whole eye is let's say closed, yeah, that they cannot really see anymore. But I also see it's more on these severe spectrum patients who might develop that. And if I now think about my patients, I also remember more in females.
Yeah. A similar phenomena in the Asian and Japanese patients, especially for the female, and they have atopic dermatitis on the face originally. But now their atopic dermatitis symptom is not so severe. After that, maybe the atopic dermatitis becomes better. At that time, they sweat. They have this kind of angioedema, mainly around the eye, not on the lip. Lip is very small, mainly around the eye. So this is our observation.
So it sounds like eye angioedema is a very distinctive feature seen in this subtype. Is that correct? Yeah.
Yeah, but they have also the cholinergic urticaria on the body. At the same time, they have mainly their main symptom is angioedema around the eye and angioedema around the eye.
So sometimes my patients would tell me if they stop doing sports when they get the rash, they will not get the angioedema. But if they, let's say, continuing doing the sports or the exposure, then they will develop the angioedema. So it's a more, let's say, prolonged exposure or prolonged severe exposure to their triggers that then causes the angioedema.
Yeah, in some cases, so. But we sometimes see that they firstly develop the angioedema around the eye only. Sometimes happen, but in some case, maybe the different.
Thank you. There's a question about, will the recording be available to watch on demand? Yes, the session is recorded. It should be available probably a few weeks later. There's a question regarding what is the protocol for steroid pulse therapy in cholinergic urticaria?
The steroid pulse therapy is conducted according to the standard treatment, which is used for autoimmune diseases such as SLE or alopecia totalis. So usually 1 gram of prednisolone is administered 3 consequential days, and then, well, as far as I know, many physicians do not add slowing down following administration of prednisolone. So they administer steroid just 3 days and stop it. And in many cases, that pulse therapy is repeated for 3 times or 4 times with intervals for a month or 2 months. I think it is really a standard way of the steroid pulse therapy.
Thanks. There's a question about what is the role of antiperspirants or medication targeting the sweat in patients with cholinergic urticaria sweat allergy type?
I do not have a feeling that antiperspirants.
Yeah. Targeting sweat.
Antiperspirants.
Anti-sweat, yeah.
So like a
have-
DO, what you do for
Okay. Well, I have never tried that. Well, I have not tried that yet. And also, I do not intend to try that. The reason is that the patients begin to develop symptoms as soon as they start to sweat. So I believe so if the sweat comes out to the skin, it is too late to prevent the symptoms. So
Yeah,
maybe
Doctor,
not even.
Before I tried to anticholinergic agent, oral anticholinergic agent,
Okay.
but I think it's not so good effectiveness. This is my experience.
I have also tried with these, what is it, some aluminium salts preparation that inhibits, or that I think contracts the sweat glands, right? I did provocation tests, put it on a part of a body, and we looked. I had no benefit, even not in the area where we applied it. So I also think it's more this sweat production down in the skin, as we have seen in these pathophysiology models shown by Professor Hida and Professor Fukunaga, that are driving the symptoms, and maybe even this inhibiting going out might be even worsening it. I'm not sure, but
okay, yes, I agree with two of you. Totally agree with you. And I have tried anticholinergic medication for several patients, not so many, but failed in all cases. However, I feel I ought to add the information that there are sporadic case reports in which anticholinergic medications are effective. So maybe some patients may get benefit, but it's very, very limited.
Thank you. How would you recommend primary care providers such as GP to watch out for? What would your recommendations for them to manage flare-ups in the disease in the community?
I think as Dr. Fukunaga mentioned, that it is most important to make a proper diagnosis. Cholinergic urticaria is not homogeneous. So I really like to distinguish or classify roughly an allergic type and non-allergic type. Non-allergic type, especially accompanied with pain or hypohidrosis. For the latter, all medications, especially for medications for chronic spontaneous urticaria, are really powerless, not effective. But for patients who shows atopic background, many medications, including antihistamine, nomalizumab, and possibly cyclosporine, are fairly effective. So it is important to make proper diagnosis, including proper classification. That's my suggestion.
And I think it's important for especially GPs to know that there are effective treatments for these patients, because I sometimes had patients who went to, let's say, some physicians for whatever specialty, or just GPs, and they were told, oh yeah, but there's nothing one can do about it. You just have to sort of live with it, and eventually it will go away, hopefully. So I think one important thing to know is also for cholinergic urticaria, we have, at least for the good proportion of patients, we have effective treatments, and send them further to the specialized treatment centers. Maybe not in all patients, but as I said, in the majority of cases, we can help those patients.
Yeah.
Thank you. The next question is about, can acetylcholine directly stimulate mast cells? Because there are studies suggesting no expression of muscarinic receptors on mast cells.
Dr. Hide, please.
There is a big controversy in Japanese society. Some certain experts argue that, but I argue against that. That means I don't believe that acetylcholine induce muscle degranulation. So
Actually, I agree with Professor Hide. Because I think that we inject acetylcholine agent directly on the skin sometimes for the local sweating test, but it makes only pain, not itching. So such a phenomenon, I think that acetylcholine does not directly induce muscle degradation. This is a clinical aspect for me.
There's one last question on anticholinergic treatment for hyperhidrosis, such as oxybutynin, is not effective. Is this correct?
I support that opinion. Not effective.
I think almost patient does not effective.
Thank you. I think that's the end of the question list. Oh, sorry, there's one more. There's one more that came in. This one comment, it's also important to differentiate it from exercise-induced with allergy, although in these cases it's confirmed by the clinical history. Is omalizumab released for cholinergic urticaria, only for chronic spontaneous urticaria? Probably more as a comment than questions, I guess.
I think the exercise-induced anaphylaxis, in my experience, they have not these very small wheels. So they typically have the typical normal larger wheels, and it's not so consistent. So they have experience, or sometimes they have something if they do sports, the next time they have nothing at all, because it depends on whatever the food they had in correlation with the exercise. So it's not as consistent as with cholinergic urticaria, where the patients typically always, whenever they have their specific threshold, they will get their symptoms and these small wheals. And also for that type of anaphylaxis, omalizumab can be a treatment option, let's say, but it's not, since this is a food allergy more, you have to depend on in which region and which country you are. You might have to argue a bit with the insurances if they cover that for that reason, let's say.
I guess, for weed-dependent exercise-induced anaphylaxis, itself being an allergic reaction. So there's often, some other systemic symptoms accompanying cutaneous lesions as well, bronchospasm, diarrhea,
Yes, they can have also add-on therapies, add-on symptoms in anaphylaxis until very severe reactions. Yeah.
Exactly. And then the treatment of choice would be auto-injector adrenaline, to reverse the process. Or
as an emergency treatment, definitely yes. As a prophylaxis, it's very individual, I think.
Exactly. As you pointed out, it might differ in different geographical region, around the world. Certainly for cholinergic urticaria, will be satellite pinpoint cutaneous lesions. Yeah.
Yes, that's right. But I like to say that it is important to educate many GP or physicians. And actually have many reference from general physicians suspecting cholinergic urticaria as a food-dependent exercise anaphylaxis and asking to identify the causative food. But if we hear or we carefully observe, that is cholinergic urticaria. And another point is that many subtypes of chronic urticaria or chronic spontaneous urticaria do not develop into anaphylaxis or anaphylaxis-like symptoms. However, cholinergic urticaria may develop anaphylaxis-like symptoms or conditions. So therefore, it is important for physicians to know that cholinergic urticaria may present anaphylactic or allergic anaphylactic type symptoms. So it is important to observe the skin eruptions, and it is important to carefully hear the condition of skin when they develop symptoms.
Yes.
At the same time, I think the photograph is really important. They should take picture by themselves. It's good information for us.
Yes.
Yeah, I think that's a very important point. Nowadays, has an iPhone, you can easily capture the pictures, collect as an album, and show the clinicians by flipping through the series of pictures. Yeah.
So use of omalizumab for cholinergic urticaria is off-label. It is not licensed anywhere in the world.
Yeah. I think that's the end of the question list. So to the audience, please remember to complete the feedback form at the end of the webinar. And we have another session coming up on the 15th of October on emerging biologics in urticaria, navigating phase 3 therapies and personalized treatment choices. And there'll be a survey at the end of the webinar, so we'll appreciate all your feedback today. With that, I will just close the session today, and thanks for attending today. Take care, everyone.